Taiwan, they had faced SARS and MERS. They had gamed pandemic preparedness. They had trained lots of people. They had what they needed in place, and they were petrified. They were really scared that a pandemic would get out of control, and they were much better prepared and much more able to execute and much more willing to execute than many of the other countries. Two is, of course, and in Taiwan, of course, I think the vice president was himself or herself a public health graduate of Johns Hopkins University. So they let the scientists, run things, and some of them were very well placed. Some of these are well organized societies. Some are a little bit autocratic, like Rwanda. But I think it wouldn't be hard to make a list of, they were frightened, they gamed it, they were ready, they had political will, they didn't hesitate to engage in first-class public health practices. There's no magic. There's no magic, Professor Nguyen knows much better than me. There's no magic to testing, tracing, and isolating. My niece was infected recently. She's a healthcare provider. She worked in the 5 days between infection, between her getting sick and her getting tested. She probably exposed more than 50 patients. And yet the state of Ohio did no contact tracing. I repeat, they did no contact tracing for a healthcare provider who possibly, she certainly exposed at least 50 people. This is, by contrast, in Victoria State in Australia, when there was an outbreak in an apartment complex, they surrounded the place with the army. They got everybody around. They said, we're not letting this spread. In New Zealand, they treat every case as if it were 1 million cases. So I think, look, some of these countries were frightened, ready, able to execute, willing to execute, engaged in good public health practices, and their goal was suppression of the virus. Now, in fairness, I think to the Italians, they woke up with a big surprise. But there's another interesting article I read recently about the lockdowns that talked about delays in locking down and delays in willingness to prohibit travel within your country, which the Italians did actually pretty well once they got going. And many believe, at least in the first wave, that was helpful to Italy. So I think in due course, we're going to see that there was a lot less magic to this than we think, and that there'll be a lot of good writing, I believe, about the determinants of countries' ability to reduce the number of new infections to a very low level. And by contrast, you had some countries, including the Swedes and partly the Netherlands, where they had hopes of early on in the Netherlands, as we talked about before, herd immunity. And then there's the UK, which just looks like it's a country that's completely incompetent. I mean, they started with a little bit of herd immunity, then they backed up, but nothing has worked. Looks like nothing's worked very well in the UK. And then you have the US and Brazil, which are just insane, where you have political leaders who in all respects appear to be people of extraordinarily limited intelligence, who have no respect for science, who politicize the outbreak, who've created an internal war between some people and others, and a culture war between some and others, in a way that leads the President of the United States today to be hosting political rallies with large groups of people with no social distancing and no masks against the advice of the public health authorities. So I think you can group these into a number of different kinds of countries, from the competent and interested and able to the theoretically competent and disabled, like the UK, to partial attempts or greater attempts at herd immunity, and then of course there's a whole range of relatively poorer countries that just don't have the capacity, and we just have to hope that COVID-19 doesn't kill that many people in the Liberias or the Nigers or the Malis or the Burkina Fasos. And Chile's an interesting case because in theory, the Chilenos have the best healthcare system in Latin America. And they've had, but they also at one time led the world in a number of infections per capita. In a way I was surprised by. I have a long personal connection with Chile. I don't know the country as well as Dr. Bakker. I know it pretty well. And We had an exchange student in the 60s who lived with us who became the head of the Latin American Pediatric Association. We've been in touch with him. And so Chile was a surprise. I would have expected Chile to be a big winner, but at least in the number of infections for a while, it wasn't. And half the population, so it has the New York problem of density. It also has the advantage that half the population lives in Santiago. So that was an interesting and a strange one. But so far as I know, they were serious, and they had what should have been a good system. I don't understand what went wrong in Chile, to be honest.
Well, maybe the public unrest that started last year, November, played into this, because the rioting and the unrest was still going on when the pandemic started, and they couldn't control it. And I think the let's say the dissatisfaction with the government, and so anything coming from the government was distrusted already immediately, played into this as well.
Okay. Perhaps we should go to the next question. I have a question still for Jan, because you made a remark earlier in our email correspondence about, you also said it just now, that in the Netherlands, before it was centralized at the Erasmus Medical Center in Rotterdam, already the intensive care doctors were discussing outplacing patients from hospitals who were overburdened to hospitals who, at that moment at least, didn't have that many problems and still had capacity, which was then taken over by a more official distribution center in Rotterdam. But you made a remark early on in the email correspondence we had that also in the Netherlands, more people died or at least didn't get the care they needed to because of reluctance.
And you mean reluctance of the patients or reluctance of the hospital?
Of the hospitals.
I'm not sure if that was a real problem. You could say if you compare the Netherlands ICU practice to the USA ICU practice, there was zero reluctance here to admit any patient, where there was reluctance, and then a reluctance based on medical decision making. And so what, let's say, benefit can we add or offer this patient when we admit the patient to the ICU and put the patient on a ventilator? And if the evaluation of the medical team is that there is nothing much to offer, then we don't admit. And that's certainly not the practice in the United States, because here, if we can offer a ventilator, then you offer healthcare, and that's it. That's great. Even if you're destined to die. And so when I talked to, and there are several aspects to this. So we had a discussion about the traditional Jews, the Orthodox Jews, that we have a big community in New York, and they more or less demand healthcare. And at one time we admitted a 93-year-old on a ventilator in shock. And I said, what the hell are we doing here? It doesn't make any sense. And they said, and one of the administrators said, well, if the Hasidic Jewish community learns that NYU is not ventilating one of their patients, one of their members, we're in trouble. And interestingly, we were, I think, with 3 intensivists in the room, and we all 3 said at the same time, great. And they said, yeah, but then they will go to Mount Sinai, and we repeated, great. Because this is not okay. And if they want to go somewhere else, that's okay. So I don't think it's reluctance in the Netherlands. I call it, there's a reluctance to do harm in the Netherlands. And that's basically absent in the United States. And that's at least for me as a medical doctor trained in the Netherlands, that's a very very difficult aspect of the US healthcare. And so benefit is completely differently defined in the US than in the Netherlands. In Chile, it's dependent on where you land. If you land in a public hospital where patients are on ventilators normally already, not in a pandemic, but on a normal day, patients are in ventilators in the hallway and in the emergency room waiting for a bed in the ICU. Or you're admitted to a private hospital with a lot of resources. That's of course, those patients are different. The way they come to your system, they're different. They're more knowledgeable, they're more demanding than the poor people that are already happy that someone will have a look at them. And also in Chile, I think there's a more humane approach to healthcare, and so more like, can we mean anything for this patient? At least more than in the US, less than in the Netherlands, and maybe the Catholic religion plays a role in that. So it's much less than in the Netherlands, but at least much more than in the US.
But then, Jan, do you think that because when patients came to Erasmus Medical Center, and of course we filled the ICU and also the wards very quickly in a couple of weeks with COVID-19 patients, first starting with patients coming from Brabant, where they were overwhelmed, and then taking care for the patients of the Rotterdam region. Very early on, we had 4 multidisciplinary team meetings a week for the patients at the ward, where there would be doctors from psychiatry, but also anesthesia, ICU, acute care, infectious disease, pulmonary medicine, but also geriatrics. And so we would discuss the medical problems of the patient, but immediately also the nurses there, immediately we would also discuss if this patient deteriorates, is at the ward at this moment, will he or she go to the ICU? And the ICU doctors were there, and so there would be a discussion. So this patient is 77, has hypertension, has diabetes, has obesity, has asthma. So no, this patient will not benefit, and we will immediately write this, discuss it with the patient, his relatives, and write it in our electronic medical record, so that at least the ones taking care in the evening or at night would not have to bother about deciding if a patient at that moment would still go to the ICU or stay at the ward. So I guess that's very different from what you say what's happening in the US. And I guess that's also very different from at least what we saw from the news from happening in Italy, where indeed what you say, also these 93-year-old Catholic ladies would be admitted to the ICU because you would go to the hospital, and if you needed a ventilator, you would go on ventilator and not thinking about will he or she even benefit from being on a ventilator or still die anyway, which would happen without a ventilator, of course, as well. So do you think, and perhaps Richard also, that these ethical discussions you have and also the position you take about what you can do with healthcare for your patients has something to do with overwhelmment of ICUs and healthcare systems as well?
Yeah, absolutely. I think that's one of the aspects why the overflooding of the system in the Netherlands was much less than, for instance, in the system over here, and also in the system in Italy. The reluctance to, let's say, make decisions the patient has a say. So have a medical assessment of the situation and then go and talk to the family is very different in the Netherlands and Italy and the US. In the US, it was very simple. There was zero ethical discussions. We never had an ethical discussion when a patient was admitted. As I told you, a 93-year-old with severe COVID and in shock was intubated and brought to the ICU. The reason is, as I just said previously, there's a simple commercial reason. If we let patients die in the emergency room because we do not intubate them, word will go around, patients won't come anymore, and there will be an after COVID time where we need these patients to make money. So that's a very, let's say, basic commercial reason. For the doctors, and that's something that I let's say, experience at least weekly. There's a huge problem in making a decision that results in the immediate or almost immediate death of the patient. And so, for instance, when we were facing a shortage of renal replacement therapy machines, a committee was put together that decided whether a patient would receive renal replacement therapy and how much. And so usually you do 4 hours, at least 3 times a week. And so the committee would decide on whether you would get renal replacement therapy, and if yes, how much. And so at one time, because the shortage increased, the committee decided, for instance, to do 2 times a week for 2 hours. A completely meaningless intervention, but at least the family would then think that something was done. And I said, this is a weird way of treating patients. And it's also in sharp contrast with the decision to either ventilate or not ventilate a patient. Because if you do not do renal replacement therapy, they will die of renal failure. Of course, not immediately. If you decide today you don't do renal replacement therapy, it can take up to a week before they finally die. If you decide not to ventilate the patient that comes in with severe hypoxemia, the patient will probably die within maybe even minutes or hours. And so there is this immediate connection between your decision and the outcome. And when I discussed this, why do we have a committee on renal replacement therapy and not a committee on mechanical ventilation? They didn't see, let's say, the absence of differences. They thought that deciding on renal replacement therapy was a completely different decision than deciding on ventilation. And in part in that decision, there's also hope. As a family member once said to me, you cannot deny us hope. If you do not renal replacement therapy, you can hope for a spontaneous recovery of the kidney, or the patient survives with severe renal impairment, and you can do renal replacement later on. But of course, if a patient is in severe respiratory distress and you do not ventilate, the majority will die. And so there are different aspects, but in general, there was a lack of any ethical thinking or decision-making, at least in my hospital.
So Jan, can I ask you a question then about the discussion in the Netherlands? Because the Dutch Intensive Care Society, they produced a handbook to prepare for the second wave we're now facing. And to, in times of shortages of beds, ICU beds, etc., ultimately decide who will go to the ICU and who not. And in that handbook, it says that if you have to decide between a patient of 75 versus a patient of 25, you would decide for the patient of 25, and without any other underlying diseases, of course, because it would complicate. And then there was the minister who said that's not on to the doctors to decide, that's the politics to decide. So what is your opinion about it?
Well, I think at least two aspects, and I think Richard can allude to this as well. There's an aspect of what's your ultimate goal. So if you want to save a life, and let's say the chances of dying of both the 25-year-old and the 75-year-old are equal, and the only goal you have is to save a life, then you should do a lottery or whatever. Because then you met your goal. If your goal is to save life years or to prevent life years lost, then it's a completely different discussion. Because on average, the life expectancy of a 75-year-old in the Netherlands is 13, 14 years, something. Of the 25-year-old, it's more than 60 years or something like that. And so if your ultimate goal is to save life years, you go for the 25-year-old, even if the chances of survival or dying are the same. And so I think that's a discussion, and I agree with the Secretary of Health. That discussion is not for the doctors. That's a general discussion that should be done outside. That's a public health thing, I think. And so I in part agree with the Secretary of Health, but it depends on the objective you have. Is it a general health aspect, or is it a practical saving lives when confronted with two patients?
Maybe Jan and Jan, I can make just a few comments. Is that okay?
Yep.
So, we've talked before about the U.S. being quite distinct culturally from any other high-income country, even though we have something in common with the Brits, the Aussies, and the Canadians. Two is, we've talked before about the U.S. healthcare system being completely unique and looking more like the system in India than it looks like the system in the Netherlands or Germany. And I should have said Germany appears to have been a winner in COVID-19 also. And one of the cultural issues in the United States that relates to health is that basically Americans believe, as Dr. Bakker said, we are entitled to, even in a system that doesn't work, we're entitled to every bit of care possible. And when the Affordable Care Act was being discussed, for example, any suggestions that you would differ from all the care possible was regarded as murdering your grandmother. In the United States, we talked about it as throwing your grandmother from a moving train. My grandmother was wonderful. I considered doing that to my mother, but I won't talk about that today. So it's a completely different culture. And then, as Dr. Bakker said, there are also a range of commercial interests in a system in which providers are competitive in many cases rather than parts of a system which are financed from the same kind of universal source. So that's one. Two is, this was really unique. I'm not aware of any time before in my lifetime when there was a need for the American healthcare system to consider triaging patients like this. There have been disasters on an acute basis, but nothing like this. Now, three is, it's my understanding, and my son, I think there are countries that thought about this very well. I'm very keen on the Norwegian approach to ethical issues, and I can refer you, Jan Nguyen, afterwards to the work of Ulla Norheim, who you may know headed the WHO Commission on Ethical Priority Setting and Investing in Global Health. Ulla headed, I think, a national commission in Norway on priority setting for COVID-19. And there are a number of other countries I know too that very early on had very thoughtful approaches to this very complicated issue. As Dr. Bakker said, what's the goal? And where do you go from there? But my understanding is in the United States, state by state, and there were committees that developed guidelines for what we call standards of care that included triage in the event that the healthcare system was overwhelmed. And this is also important in the United States because unlike the other high-income countries, there are huge legal and liability issues in the US. In the United States, everybody likes to sue for medical malpractice. And so when it came to the question of triage, healthcare practitioners needed the cover of state-mandated standards of care, or they would immediately be subject by family X or family Y to suit when they said, well, you pulled the ventilator on my grandmother and she died, and yet you had no basis for doing that. By contrast, if the state governments, as they did in Arizona, which I know, mandated following these certain standards of care, then it provided protection to the healthcare providers. So as long as they were following those standards when they made their triage decisions, they would be immune from, they would sue anyway, but in theory, they would be immune from suit. So culturally and legally, the US is completely different. But I do think there was a lot of thoughtful work. I don't know New York as well as some other places, thoughtful work that went into thinking about standards of care and triage for the first time. But happily, in most places, they never got there. They never, in most places outside of New York, maybe a little bit in Massachusetts, happily, they had these standards of care in place, but they never really had to implement. They may have made individual decisions than a 93-year-old. And the other thing is, so in New York, you would have Hasidic Jews as an important political constituency and commercial constituency. An issue that would arise elsewhere would be ethnic diversity, and in New York, ethnic diversity and disparities. And the fear that you're already dealing with a pandemic in which Black people and Latino people were disproportionately affected, and therefore you were much more likely to pull the plug on Black people and Latino people, who, especially Black people who are, and Native American people, who have very high rates of hypertension, very high rates of asthma, very high rates of obesity. And those were things that most practitioners really didn't want to have to deal with. But I think to a large extent in most places, they got up to 92, 93% ICU capacity for the state of Arizona as a whole, but there were still beds even in Phoenix, in some competent hospitals. So again, you have to think of the US as a bizarrely different place with no real healthcare system, with lots of decentralized actors. And I mentioned, Dr. Bakker, the last time something you said, which was you mentioned that if a 93-year-old Chassid wouldn't be treated at Langone, the family would shop and go someplace else. Well, I had mentioned in one of our previous discussions that I know a state in which, when I know some cases in one state, for example, where that happened. You know, the family came in and the healthcare provider said, you know, grandma's 93, she's morbidly obese, she's in shock, she's septic, she's going to die. We encourage you to take her now to this hospice or bring her home, and here's what we would do to make her comfortable. So they just left and went to another hospital, and eventually they could find one that would treat her. So I hope that adds a little bit of value in thinking. You have to think of the US all the time as a completely unique place culturally. It's a federal system with no real healthcare system. But in this case, there was a lot of thoughtful work done in most places on standards of care. But I think they never really had to go to implement it. And I'll send you some references, Jan Nguyen, later today. And Jan Bakker, please correct me if I'm wrong.
Yeah, we were, at least at NYU, we were only on one day. We had a discussion together that we were meeting the New York State guidance on pandemics, and that we needed to started to triage patients on SOFA scores. A very weird way of dealing with it, because at least from my let's say expertise, the SOFA is totally inadequate to be used in COVID. We're doing a study now to prove that. And I had right of speak because I invented the whole SOFA score. So I had an idea where SOFA was coming from. And I said it's totally not applicable to the COVID situation. But we were at one day at the brink of doing it, and everybody was scared to death to go that way. Because, and that's what you alluded to as well, discussion with patients or family members about what to do usually end up like you said, I would recommend you, or I would encourage you, or I would advise you, or something like this. And so basically what's happening if you think of this from the context of the patient or family, is here's all the data, please make a decision yourself. I've had many conflicts, not only with the non-Hasidic Jews, but I had a lot of conflicts with the Hasidic Jews families because they demanded care. And I used my typical Dutch approach, and I said, I'm very sorry, I'm not going to do that. I'm willing to take your father or mother or whatever to another hospital. I will do it for free. You don't have to pay me, but I'm not going to do this. I'm very sorry. And then when you as a doctor, as the individual healthcare provider, take the responsibility for what's happening and then get into a discussion, at least up until now, I mean, I'm practicing over 2 years here, and it's my standard approach. I've always been thanked by family afterwards for being so candid and being honest on what I wanted or not wanted, and what I thought was let's say, important. And so I think it's also a way of communication that basically in the US hardly any doctor does. I admitted a colleague, a cardiologist, to the ICU with COVID. And I had the typical Dutch discussion with this patient about values in life and why do you want to do all of this. And so at one point he said, you have an accent, where are you coming from? And I said, oh, I was trained in the Netherlands. And there was a long pause. He looked at me and he said, that's where they do euthanasia. And I said, well, only if you ask for it. So you're not in trouble. And so at the end of the conversation, he said, this is remarkable. Neither myself, I have never had a discussion like this with any of my patients, but no one in the whole process of coming to the ICU and COVID stuff, no one ever talked to me like this. So it's a way that's not being practiced in the US, which puts a lot of families and patients, I think, in a lot of trouble because they have to make decisions over stuff that they have hardly any clue.
I think, Jan Bakker, if I might make both a serious and a humorous comment, my son is 100% in agreement with you. He behaves like a Dutchman in the ICU, I think, most of the time. And he's assured the rest of the family, especially when they're not happy with me, that when I'm ill, he'll be the first one to pull the plug. and he has my son is my healthcare proxy. So
that's good.
So I'm glad that Jan Nguyen is taking advantage of me while he can. Please go ahead.
Yeah, exactly. Before your son gets a hold of you. So can we move for a last question? Because what I wanted to discuss with you, that's more general remark, is about the availability of medication and the availability of vaccines for the coming months or years. Of course, we know that Trump is very pro hydroxychloroquine, although all the studies show that there's no effect. Remdesivir, of course, is made by Gilead, which is a US-based company. Vaccines are produced, luckily, more spread over the world. So could you comment on where all the drugs and all the vaccines will go to? Will it be to the highest bidder and then thus probably the United States, or will there be other countries be able to access vaccines and drugs for COVID-19 as well?
Well, it's not my specialty, but to make it simple, why should it be different when we had a shortage of ventilators? I think it will be the same thing. When we needed PPEs and we needed ventilators, we were each on our own. And so there was a whole market of bidding to get the ventilators or get the PPE. And of course, the companies took advantage of it. And so the highest price was taken. And I don't think that will be very different for the vaccines. I mean, there will be a lot of political pressure, at least in the US, to get the vaccine before November 3rd. That's a political thing. But I think it won't be very different. The one with most of the money will get most of the market in this case.
Yeah, I don't know. You know, I mean, the situation with drugs as well as vaccines. I think what Dr. Bakker said is certainly an important issue, and there's a real possibility that there'll be a strong correlation between who's got the money and where the vaccines will go. But I think there's also a substantial effort, you know, underway now to try to create mechanisms for approaching the distribution of available vaccines in a more international and more, you know, ethical way. Now, the US is not going to participate in that. I thought I read yesterday that Germany is not participating either, but many other countries, I think all other high-income countries have agreed to participate. So I think this might be a case where, although it will be confusing clinically, probably the best scenario is that a number of vaccines turn out to be effective, that the national origin of those different vaccines will be different. You know, if it turns out an American manufacturer is the only one with a safe and effective vaccine, Dr. Bakker, I think, will turn out to be completely correct. By contrast, if it turns out that the Chinese, the Russians, the Brits, the Americans, the Germans all have safe and effective vaccines, then I think there's a much greater likelihood. Now, the Global Alliance for Vaccines and Immunization has already struck a deal to try to ensure some supply for low and, you know, lower middle income countries. But of course, there has to be enough of a supply to distribute. And that's something I would worry about, because whether I was in the Netherlands or if I were in Norway or I was in Guatemala or the US, you know, as long as the virus is circulating widely someplace in the world, it's gonna make its way back to other places. So if there was ever, as we talked about in the first session, you know, COVID-19 is the perfect global health story. Everything you're going to learn and think about in global health is reflected in COVID-19, as Dr. Nguyen said so well, and you know, which caused him to raise the first set of questions for me, you know, 4 weeks ago. So I think it's really fundamental that COVID-19 be addressed effectively everywhere, or we're forever going to be, you know, fighting it all around the world. So I'm slightly optimistic, but not wildly. Now, I think the other thing that Dr. Bakker mentioned is really fundamental. And I think the approach of the US government to the vaccine is one that has already done an enormous amount of damage to the likelihood that the vaccine will be taken up by everyone who needs it. Because, you know, we had our anti-vaxxers in the United States, and they tended to be kind of left-wingers, free thinker, hippie, I'm exaggerating, hippie types, or right-wing evangelical types. And now what we've got is a kind of the progressives who are, what you would call center left in the Netherlands, right? The progressives have no confidence whatsoever that a sound scientific decision will be made about this. And so for the first time ever, the group of people with the highest immunization rates in the country are petrified that Trump is going to force the Food and Drug Administration to approve a vaccine that's not safe and effective. And therefore you won't even know. You just won't take it because you won't have confidence. And the US has a much larger impact on the world than it should have. And what happens here is going to spill over, and you see it already. And the last, we need a world in which vaccines are approved when they're safe and effective, in which people believe in them and they immunize themselves and their children. The last thing we need is to wake up and have more skepticism about the safety and efficacy of a measles vaccine or a DPT vaccine or an HPV vaccine. This has the making of an international disaster largely fueled by Donald Trump in a way that will take years to recover. I'm hoping that won't happen. The person at the Food and Drug Administration who's responsible, if they allow him to be, is said to be a person of a remarkable talent and ethics. But don't be surprised November 1st if he leaves the job, makes a public statement, and they go ahead and approve a vaccine. I don't know, Dr. Bakker, if you agree with my comments, but that's I think an enormous and uniquely American risk right now.
Yeah, I completely agree. And to be honest, if there is a vaccine in the US available before November 3rd, I won't take it as well.
Yeah.
Or take it and keep my mask on.
Yeah, and I spent my whole life, working on childhood vaccines and trying to enhance the health of young children in poor countries, partly through enabling a greater distribution and use of safe and effective vaccines. Yeah. And I think there'll be tens and tens and tens of millions of people just like you. Yeah. And I wouldn't either. I'd be petrified.
Yeah.
People are going to be afraid. An important share of the American population is going to be afraid to take a vaccine if it's approved while Donald Trump is president.
Yeah, I agree.
Okay, thank you for your comments and deliberation. Yeah, it's how do you say? Good way to end this, or not a good way to end this? It's just how you look at it. So, are there any questions and remarks from the students?
I have a question.
Mm-hmm.
How do we ensure that low-income countries get vaccines too?
I said that Dr. Bakker might want me to take this one first. So Danielle, I mean, that's a really fundamental question. Both when, you remember the first thing I said the first day was the health of anyone, anywhere is the health of everyone, everywhere. So both for ethical reasons, for health equity reasons, and more, it's really fundamental that when a vaccine is deemed to be safe and effective, that it's available everywhere. So we talked a bit, Danielle, about the Global Alliance for Vaccines and Immunization, and I can try to send Dr. Nguyen a link to what they're doing. But Gavi is the coordinator and the leader of work on vaccines in low and lower middle income countries, supported by all of its participant countries, high, middle, and low income as well. And they have made an arrangement which is trying to ensure that if a vaccine is safe and effective, that vaccine will be available widely in low income countries at a price that I'm not sure Gavi already arranged the price or would arrange it on some basis close to its cost. So in principle, the world has made important progress on setting out such arrangements. Gavi has shown before that it's done a good job in helping to develop advanced market commitments for vaccines and get them out, like with the pneumococcal vaccine. So I think the world's done a thoughtful work on this so far. But if it turns out that there's a mad grab for the vaccines by high-income countries when only one is approved, then it will be much more difficult. But I'll send Dr. Nguyen a link to the arrangements that the Global Alliance, and I do think that's the most thoughtful, sensible approach that could have been taken so far to trying to ensure widespread distribution in those countries, because Gavi is widely appreciated, well regarded, and this is clearly part of its mandate.
Okay, there's also a question from Luca, Richard, in the chat box, which is more about if you have limited number of vaccines, how should you distribute that among the population of your?
So I'm sure Dr. Bakker will also have thoughts. So, I believe what you're seeing, and you'll see more of, is national. This will be the WHO will have a panel that will make some suggestions, but then national bodies and subnational bodies in every country with competence will also be issuing guidelines for the distribution of the vaccines. I have great confidence that Norway will lead the world in developing guidelines that will take very serious account of ethical issues as well as health and social issues, and that'll have a big impact on WHO, and WHO will have a big impact on the lower middle income countries. But the short answer is, I think, and Jan Nguyen and Dr. Bakker should correct me, you're going to see at every level of government a policy statement on, in principle, guidelines for the distribution of these vaccines in a way that maximizes the achievement of their health goals, whatever they are. And in some countries, I think, will also very much factor in ethical issues very explicitly. And in other countries, that'll be a little bit less so. Dr. Bakker, please correct me if.
Yeah, I think the global health should lead, but there's also something like what keeps the country together. And so what we call essential workers. So if you want to keep your country running, then there's an economic aspect, and so get businesses going. And that's why supermarkets were still open, because you need food. And so those businesses need to run. But of course, police, firefighters, ambulance personnel, healthcare workers, stuff like that. You need those as well. And so getting, let's say, the basis of your society immunized as soon as possible will make it much easier to get the country running again and maintain your global or your country health aspect. And that will be an interesting discussion, also related, of course, to how much percentage of people can you actually vaccinate. Completely different discussion if you can vaccinate 25% of your population or 80%. That's, of course. But I think that's the global elements that should be in the discussion.
I have a case study. So if I were Professor Nguyen, and I know the students are glad that I'm not, if I were Professor Nguyen, I would immediately give you a scenario or two and ask you to form some teams and develop ethical guidelines for the allocation of scarce vaccines in February and March of 2021. And I would say, I'm the Prime Minister of the Netherlands. The Netherlands is likely to have enough vaccine in March 2021 to vaccinate about 1/3 of its population. And I would like you, as the National Committee on the Ethical and Fair Distribution of these vaccines, to outline for me and the Parliament what you believe would be the soundest approach to such distribution. And you must, of course, inform me as the Prime Minister of the rationale for your suggested distribution, both in terms of health, in terms of ethical issues, in terms of price, in terms of cost effectiveness, cases averted, deaths averted, et cetera. And, as a graduate, as the Prime Minister, who's a graduate of Johns Hopkins, I will, of course, grill you thoroughly. And I would try to create a scenario in which there's absolutely no perfect answer. I had that for HIV in the early days, and 2 bioethicists helped me come up with a case that I'll share with Professor Nguyen, although, Jan, it's in the materials for the book. And we developed a case, and I promised my students that they would absolutely have the worst headache of their life after the class because there was no perfect scenario. And no matter what they did, some people would live and some people would die in the early days of HIV. So I would encourage you, if Professor Nguyen does that to you, good luck. But I would encourage you to think along those ways, because one way or another, every country, every governmental authority responsible for the allocation of vaccines will have to do that until there's enough vaccines for everyone, and there won't be for some time. I'm not confident about the ethical side in the US. I'm exceedingly confident that my Norwegian friends will have ethics and fairness first, and everything will follow. In the US, it'll be interesting and complicated. Jan, you're muted. Jan Nguyen, you're muted.
I changed my setup, so the mic was, the unmute was somewhat different than what it was before. Are there any other questions or perhaps additional comments to end this session from Richard or from Jan? Or no? No questions in the chat? No live questions? Jan, anything to end with?
Jan, if I may, I just want to say what an honor and pleasure it was to meet Dr. Bakker. I'm sure my son knows his work well, and we'll look forward to meeting him personally. And I want to thank you again for the opportunity to meet on 3 separate occasions with you and your students. It's always exceedingly enlightening and interesting and enjoyable for me. And I hope that I added some of the value that you had hoped. And I wish everyone well, and look forward to reading about the impact that all of you, I'm sure, will have on the world of global health in the future. So thank you very much again.
Thank you very much.
Thank you as well. I would like to express my thanks. It's really good to participate in stuff like this. And I really enjoyed the discussions that we had. And I really like the idea of Richard to make these groups and come up with a plan. And if any of the groups is interested to make something for ICU, which is rather challenging, but how to deal with intensive care capacity in pandemics, I would be happy to participate in that. So thank you very much for the invitation.
Okay, Jan, thank you very much for your participation and your insights in ICU care and ethics and overwhelmment in the US and in New York. And so if there are students who would like to do this together with, so on the one hand, do this assignment by Richard Skolnik about implementing a vaccine strategy if you can only vaccinate 1/3 of the country versus how to go about with shortages on the ICU during a pandemic, then you know how to contact me or directly contact Professor Jan Bakker or Professor Richard Skolnik as well.
Yeah.
Okay, so thank you both. Thank you all for the students for attending. And then we'll end this session and I'll see you all back tomorrow morning. Thank you very much.
Okay. Bye.